Non-anesthesiologist administration of propofol for gastrointestinal endoscopy, European Society of Gastrointestinal Endoscopy, European Society of Gastroenterology and Endoscopy Nurses and Associates Guideline, updated June 2015. Introduction. A strong interest in the use of propofol for sedation during gastrointestinal (GI) endoscopy has been demonstrated in all European countries where nationwide surveys have examined sedation regimens used for GI endoscopy. In several countries, there has been a tendency for propofol sedation to replace traditional sedation based on the administration of benzodiazepines, either alone or combined with opioids. The Guideline on Non-anesthesiologist Administration of Propofol, NAAP, for GI endoscopy, published in 2010 by the European Society of Gastrointestinal Endoscopy, ESGE, European Society of Gastroenterology and Endoscopy Nurses and Associates, ESGENA, and the European Society of Anesthesiology, ESA, aimed to provide a qualified basis for GI endoscopists and endoscopy nurses to provide propofol sedation. New evidence that has become available since then is discussed in the present update, and new recommendations are issued. The guidelines cover care provided to any patient undergoing GI endoscopy. They are not designed to be rigid and cannot replace clinical judgment. Furthermore, their implementation may be subject to domestic regulations or local policy, and they should only be used with the agreement of the relevant domestic regulatory authority or local policymaker. Main recommendations. MR1. The authors recommend that the type of endoscopic procedure and the patient's American Society of Anesthesiologists, ASA, physical status, age, body mass index, Mallampati's classification, and risk factors for obstructive sleep apnea, OSA, be assessed before each procedure with non-anesthesiologist administration of propofol, NAAP. Strong recommendation, moderate quality evidence. MR2. The authors suggest primary involvement of an anesthesiologist in patients of ASA class greater than or equal to 3, with a Mallampati's class greater than equal to 3 or other conditions that put them at risk of airway obstruction, e.g. pharyngolaryngeal tumors, in patients who chronically receive significant amounts of narcotic analgesics, or in cases where a long-lasting procedure is anticipated. Weak recommendation, low quality evidence. MR3. The authors suggest consideration of capnographic monitoring during NAAP in specific situations, including high-risk patients, intended deep sedation, and long procedures. Weak recommendation, high-quality evidence. MR4. The authors suggest propofol monotherapy except in particular situations. Weak recommendation, high-quality evidence. MR5. The authors recommend administering propofol through intermittent bolus infusion or perfuser systems, including target-controlled infusion, TCI, and consideration of patient-controlled sedation, PCS, in particular situations. Strong recommendation, high-quality evidence. MR6. The authors suggest that patients listen to self-selected music during upper and lower GI endoscopy procedures. Weak recommendation, moderate quality evidence. MR7. The authors do not suggest using pharyngeal anesthesia during propofol sedation for upper GI endoscopy. Weak recommendation, moderate quality evidence. MR8. The authors suggest using the post-anesthetic discharge scoring system, PADSS, to determine when patient recovery is sufficient to allow discharge. Weak recommendation, low quality evidence. MR9. Minimum discharge criteria should be fulfilled before discharging a patient. The authors recommend that patients who have received combined regimens and all patients of ASA class greater than 2 should, upon discharge, be accompanied by a responsible person and refrained for 24 hours from driving, drinking alcohol, operating heavy machinery, or engaging in legally binding decisions. Advice should be provided verbally and in written form to the patient, including a 24-hour contact phone number. Strong recommendation, low quality evidence. MR10. For patients of ASA classes 1 to 2 who have received low-dose propofol monotherapy, a 6-hour limit is suggested. Weak recommendation, low-quality evidence.